Merci beaucoup Thomas, et bonjour tout le monde, mais je vais parler en anglais maintenant. Okay, well, as Thomas said, I'm a professor at Imperial College Business School, and my background is really quite mixed. I started out as a geographer and then did a PhD in economics, and for the last 15 years or so, I've been really working very much on healthcare and innovation in healthcare. And I had to sort of stop on the way before doing that by looking at urban policy and urban development, but again, looking at innovation in that context. So I've got something of an unusual perspective on this matter, I think. And what I want to do today really is just to move away from the technology itself. And we've heard some fantastic stories today about wonderful new technologically based innovations. And my interest really is in the real world out there and how we get those innovations actually taken up and embedded and spread and made mainstream in health systems. And of course, a lot of the world is not like Switzerland, England, USA, Europe. It is resource poor, so we need to think about those countries as well. So what I'm going to do is just spend a little bit of time talking about the global health challenges. And I don't want to dwell on this because we know what these are pretty well, but I'll give you a couple of other ones which perhaps are not so well known. And then I want to talk about why we need new thinking about technological innovation in healthcare. It's no good just focusing on the big science and the whizzy, wacky, sexy technologies that we're talking about at the moment, and then give you some final thoughts on what I see as being the big challenges in getting those ideas taken up. So I'm not going to dwell on this because we know most of this anyway, but we have an epidemiological shift taking place, a move away from infectious diseases to the diseases of affluence. We have an aging population around the world, not just in the developed countries, but now increasingly in developing countries as well. And of course, lots of associated conditions around that. A vast tsunami of dementia and diseases of aging, which is going to envelop us in the not too distant future. We have a huge problem over obesity, as we've heard. And if we go back 100 years, exercise was cheap. We all did hard labor, difficult jobs, and food was expensive. And of course, it's the other way around now. And we've got to make a conscious effort to get exercise. We've got to join a gym, and we can consume our cheap McDonald's, whether it be in London or Basel or Beijing. So health systems are adjusting, and they're not necessarily adjusting in the right way. We're just doing more of the same, actually, or we have been until recently, focusing on treatment, building new facilities, taking people into hospital, and we've got to move away from that. So we know all that, but there are a couple of other things that I just want to mention in this epidemiological shift that perhaps are not talked about enough either. And road traffic accidents are a huge, huge issue, and they're going to change from being the 9th largest cause of death and disability to the 3rd largest cause of death and disability by 2030. And of course, that is a north-south problem. If you just take the map here, this just shows the number of deaths per 100,000 people. And of course, in Europe, most of Europe, it's pretty low. Switzerland's 4.3, by the way, not quite so good in Switzerland. Romania's pretty bad, USA is pretty bad, but of course, it's the south, it's those developing countries where a lot of this happens. And in fact, I was in Beijing last week, sitting in the back of a cab at 2 o'clock in the morning, which managed to crash into a brick wall, and luckily nobody was hurt. But it is a very real problem, and it's a very real health problem. Something else, we are seeing a resurgence of infectious and vector-based diseases in developed countries as the world globalizes, as we travel more, as we fly more. And that's in Yoyogi Park in Tokyo just a few weeks ago. Closed for 2 weeks, the park was, because they had to spray it to eradicate dengue fever, which had broken out right in the middle of Tokyo. So new things, new challenges, new epidemiological challenges are beginning to emerge. One other thing, it's by no means a rosy picture in the developed countries. That's London, one of the wealthiest concentrations of culture and politics and power and economics in the world. And what this shows is average, you can't really see it on the screen, but take it from me, it's average life expectancy around each of these subway stations in London. And the point is that if you go from here, Oxford Circus, where the average life expectancy is 96, 10 stops down the central line to there, life expectancy drops by 19 years. So there are huge imbalances, even within the world's most developed cities, in access to healthcare and quality of care and health outcomes. And fundamentally, this is a problem, and this is a question of money and resources. It's about money for healthcare disappearing into a sort of bottomless pit. We can never spend enough on healthcare. And the way that is manifesting itself is different depending on where you're sitting. And in the developed world, of course, as we all know, this is about coping with escalating costs, resource constraints, rising demand. We're getting older. The better healthcare becomes, the more expensive it becomes, the more we demand it. So there's a huge problem over dealing with cost inflation in the developed world. Here we are, Barack Obama, before Obamacare came in. And it's the same in the UK. There are various estimates for what the gap between what is estimated that we should be spending on healthcare in the UK and what the National Health Service will actually be spending if we don't have a substantial increase in funding. And that gap ranges from 20 billion to 60 billion pounds within the next 5-10 years. So a big, big issue. Of course, in the poorer countries, it's different. And a lot of this is really more about increasing access to care. And what do I mean by that? Well, as we all know, again, there's huge shortages of health workers in the developing world. And of course, a huge oversupply or surplus of health workers in the developed world. So access is an issue. And coverage is an issue. Universal coverage is needed, but it's by no means nearly there. And if that box contains the people who are covered by healthcare insurance in the developing world, and what we need to do is to expand that box out to cover more services, more people, reduce costs, and that is a big challenge as well. So, as everybody says, well, fine, but innovation will solve all this. We need to be a bit creative. New technologies will help. We can do it. It's the sort of man on the moon problem. But with a bit of effort, we can do it. And of course, that's fine. But let me just explain a little bit why I think actually what we're doing at the moment is not necessarily the right kind of innovation for solving some of these problems. Lots of science in healthcare. There's no problem with the basic science. We're good at that. And there are various estimates for how rapidly the extent of medical knowledge changes, ranging from 15, 16, 17, every 15, 16, 17, 18 years, right down to every 18 months. And I think it's probably somewhere in the middle, but there's no shortage of basic science, big science going on. So why do we need new thinking? Well, one issue, I think, is the accessibility of the innovations that are developed from that science and the extent to which they're accessible to the poorest people in the world. And the medical or healthcare technology industries are huge. We spend something like $7 trillion a year on healthcare around the world. And the industries that provide the inputs to health services, biopharma, medical technologies, IT, built environment, which is often forgotten about, account for a couple of $1 trillion. So there's a huge industry out there developing new ideas, being creative, generating new innovations. And the problem, of course, is that most of those end up in the developed world. 87% of that expenditure is in Europe, North America, Japan, and Australasia, and so on. A huge imbalance there. So we're not developing the right technologies for providing better access to health services in developing countries. The second issue, which I mentioned just now, is that technological innovation is something of a double-edged sword, a mixed blessing for policymakers and healthcare providers in developed countries. Why do I say that? Well, it's because the better the technology, the more we can do, the more problems we pick up, the more people we can treat, the more expensive it becomes. And there are various estimates for what proportion of healthcare cost inflation in the US is represented by technological innovation, but they range from 27% to about half. So a very substantial percentage of cost inflation is to do with technological innovation in the developed world. So I think we do need some new thinking, and the question is, what is this new thinking? Where's it coming from? And I just want to spend a few minutes now talking about disruptive innovation and frugal innovation, which has been a topic that's become something of a topic in vogue, really, in the last 10 years. Sometimes called disruptive innovation, sometimes called frugal innovation. Frugal innovation is really the counterpart in developing countries. And without going into too much detail, essentially it's about simplifying technologies, stripping out the unnecessary features. And since we're in Switzerland, I thought I'd include a Swiss example. Of course, there isn't really a Swiss Army knife like this, but somebody did actually say to me earlier today, I wish I had one. So, but we don't need all that functionality. We don't need all the functionality in our phones. So disruptive innovation or frugal innovation is about simplifying, cheapening, but it's still good enough. It does the job. And I mentioned mobile phones. Well, there's an example of executives from Nokia employees working for Cambridge University to produce a simple, cheap smartphone for elderly people. So it's all over the place now. The nano car, the $300 house. Lots and lots of examples of creative thinking to produce objects that are good enough, they do the job, but they're appropriate for a different kind of setting. And increasingly in healthcare, we're seeing examples. We're seeing examples of cheaper, simpler ECGs at the top. Very well-known example, that is by GE. Secondly, down that list, actually pretty complex innovations, but business model innovations where hospitals are extending out their services and innovating in their supply chains and financial models to extend the coverage of healthcare to poorer people. And that's coming back to Europe now. That Finnish example, Coxa, has taken lessons from India. And the last one there, point-of-care testing. Lots of advanced science in there. but hugely radical, hugely disruptive, certainly disruptive in a developed countries setting, but very, very cheap. So disruptive innovation, frugal innovation is much talked about and is there. It's all around us. A lot of it is bubbling up from the developing countries. And when it comes back here to Switzerland, to England, to Finland, to the US, it has the potential to really disrupt healthcare systems. It's not just about the obvious technologies, the medical devices, the information technology and so on, new drugs. There are other areas where I think we need to make a lot of changes and which have the potential to impact on the quality of healthcare and access to care. And housing is one. We're in the middle of a huge urbanization around the world, the greatest urbanization that we've ever seen. But something like 250 million people live in poor quality housing. Now that's a huge opportunity. It's an opportunity to build a better urban environment, better sanitation, but also an urban environment that's designed so that people can live healthier lives. When they become richer, they can be encouraged to walk more. And the challenges, of course, are huge. I mean, we need to build another 106 million homes in the next 10 years simply to cope with demographic change. But the opportunities are there as well around housing. And the biggest changes in life expectancy are not to do with drugs, medical technologies, medical devices. It's to do with the basics, the housing, the sanitation, and so on. We need to have an infrastructure that's fit for purpose. You know, we've got to move away from these hospital-centric models, which are expensive, which are no longer needed. And the hospital is not a healthy place to be anyway. And we've got to make sure that countries which have got emerging, developing health systems don't reproduce the outmoded models that we've got in Europe and North America. And new technologies have a huge prospect for doing that. In London, in Zurich, and whatever, we need to think much more about the urban fabric and how we encourage people to walk, and smart cities, encouraging people to lead healthier lives by putting in place appropriate technology, giving them the data, giving them the information, is part of the story here. So it's not just about the obvious medical technologies. So finally, will we be able to do this? What are the big issues around actually making this happen? And I think the really important thing to say is that it's not the technology, it's the people. And I was standing by the, I don't know if the gentleman is in here at the moment, but I was getting a coffee just now over there in the coffee point, and we were trying to work out how to use the machine, and a bit of it fell off, that brown coffee machine. And I'm sure the technology is fine, it's robust, it's just the people using it. So it's organizational issues, people, human issues that are a problem. And of course, healthcare systems are hugely complex. And that's a system dynamics model of sorting out Afghanistan. That's a true story, that is. General McChrystal said that. And health systems are not dissimilar, actually. That's the US health system. And of course, making innovation happen where you've got professional silos, financial silos, organizational silos, embedded cultures, all sorts of strange feedback effects right across the system is very, very, very difficult. The developing countries actually, there's more opportunities there. They don't have that level of complexity in those health systems, even though there are, of course, professional and bureaucratic silos and problems. So finally, really, I think, for me, it's the technology is great. We need the technology and keep developing the technology. But to get it taken up and spread and embedded in the world, we need a much deeper understanding of the world within which it's being deployed and the complex relationships between technology, health service delivery and the business models around that, the wider infrastructure, and the broad geographical and policy context within which it's being deployed. If we get that right, then all the things we're talking about at the conference will make a huge impact. But if we don't understand that, it's going to be a long haul. Thank you very much.